Hi, I'm Ray Jones and I'm Professor of Health Informatics at the University of Plymouth. Welcome everybody. Please do introduce yourselves there in the chat room. In a minute Allen Wenner will take over. But before he does, I'm just going to give you a few technical bits about using the webcasting. If you do have any technical problems, you can contact CETO. If you look down in the bottom right hand corner down over there, you'll see there's a link that you can actually click to find out help about technical problems. I don't know if CETO's mobile is working this morning, but if you do have any problems, try that. The other thing that you can do is, if you notice above my head, there's a thing saying if the chat room freezes, you can press F5. So you can try pressing F5 if you do have problems. Hopefully you've sort of worked out where everything is. Down the bottom there you've got the chat input box, so do type away. As you'll realise, you've only got a limited amount of space for chat, but hopefully it's enough for your comments. When typing a message, remember to preface it so that if it's a message for Alan or whether it's a message for somebody else in the chat room, that would help. And one last thing is that we will be recording this. We're recording, first of all, what's happening here in this video window, and that will be made available on the archive. We will also be recording the chat as a transcript. So if anybody would like a copy of that transcript afterwards, please email me, ray.jones@PlymouthACUK. Again, if you want to email me, the contact is down there on the webcasting page. And the very last thing before handing it over to Alan is a quick commercial break, is that we do have an eHealth module which starts in October using this sort of delivery, and you can get more details about this by clicking on the link on the bottom right of the screen after Alan's finished with his presentation. So it gives me great pleasure now to hand over to Alan, and he'll take it on from there. So, Alan.
Thanks, Ray. It's a real pleasure to be here. This is one of the finest webcasting rooms I've ever been in, and certainly here at the University of Plymouth, it's a pleasure. I'm going to talk about my experience as a practicing physician in the use of patient-entered data in 50,000 cases, and show you where we are today at our clinic in Columbia, South Carolina, in the use of technology to empower patients. As references, I am a contributing author to all of these books, but I do not receive royalties from their publication. I will reference those in this talk. The assumptions I'm going to make is that you understand that computer interviewing is an acceptable medical practice. This is in the medical literature. An excellent review article was published 5 years ago by Dr. John Bachmann from the Mayo Clinic, and I'm going to assume that all these issues are behind us. Also, I want the audience to understand that I am the clinical director for Primetime Instant Medical History. We make information systems that gather history from patients for most all of the major electronic medical records vendors in the United States. And lastly, that you agree that we need digital information in order to populate electronic records so that we can meaningfully review outcomes appropriately. Let's think about what happens when a patient calls a doctor. Often when the patient calls a doctor, there's a delay in which the patient has a symptom, has to call up, has to get the appointment scheduled, and then there's a delay until the patient can be seen. What we tried to do is take this from a patient standpoint and see if we could get rid of these delays and improve not only the data quality that the physician would have in seeing the patient, but also improve the patient's experience so that it could be better access through faster care. So in our pre-visit consultations, from a patient perspective, we added the history of the present illness and the medical history to the appointment information and sort of think about what that might do in the medical workflow. We'll explain what our approach has been to changing how healthcare is delivered at our clinic. we believe the portal, or the physician's practice on the internet, should be the dial tone of the office practice. So what we began doing is allowing patients to assist with the appointments, and we found that patients could actually make appointments at much wider times, even in the evenings, and then they could actually add a structured pre-visit or pre-consultation history using instant medical history to that appointment, so that we would have a better information before the patient actually came in. So the patient no longer, or rather has the option of, instead of calling the office and having been offered a patient appointment, the patient could log on to the portal, actually do a pre-consultation interview, and even if the patient calls the office, we advise them to go to the portal, and then the portal data becomes the data for the visit, and then the patient comes to the office. Now, an interesting alternative is the patient's data may be adequate for treatment, and the patient's happy. So let's see what that actually looks like at our office.
Okay, Mrs. Jones, I've got you down to see Dr. Wenner tomorrow morning at 10:30. Okay, and do you have access to the internet? You do? Great. Well, if you would give me your email address, I will send you a link to our website so you can complete your questionnaire before coming in.
There's a chance you might need to come
Yes,
in for an
ma'am.
appointment.
Yes, ma'am. All right. Thank you very much, and I will send that to you shortly. Thank you. We'll see you tomorrow at 10:30. Bye-bye.
Okay, what we heard the receptionist do is give the patient the opportunity to go to the website instead of simply coming in, and make the visit a bit more efficient. Now, one option is we can send the patient a link, or the patient can simply go to drwenner.com, and I will invite any of you to go there and try a pre-visit interview. Simply use the name test, and you'll have that same experience that our patients have. This is what it looks like, the pre-visit interview at drwenner.com. This is our website. It simply allows the patients to visit us instead of calling on the telephone. The patient completes the appointment request and then simply enters his complaint. In this case, knee pain is the complaint that he's being seen for today. On the internet, the patient is advised to simply answer these simple questions. Yes, no questions, or simple responses are necessary. So the pre-visit interview asks the patient's questions. It then translates those answers into digital data. In other words, provides medical terminology that can be used for discrete data search. It separates the negatives and the positives for the physician so that the physician can formulate a diagnosis very quickly by looking at the information, rather than simply asking the questions of the patient for himself. In addition, it scores standardized instruments that are gleaned from the medical literature over the past 50 years that standardize the history in a more standardized way. And finally, it presents the data to the physician in a medical record format, so it begins the medical record for the physician. Indeed, it's a pleasure to be here in the UK talking about one of England's greatest professors, Dr. William Osler, who said if you talk to the patient long enough, he'll tell you what's wrong with him. And in fact, that's what instant medical history attempts to do, is gather a subjective interview in the same way that a physician who had enough time to speak to the patient would do. And thinking about it, it simply asks questions and then it branches, much as a clinician would do. If you said, do you have a sore throat? Then it would say, well, how long have you had a sore throat? And so forth. So this artificial intelligence, if you will, is response-based on the question that triggers responses to each answer, yes, no, or maybe. And then those responses can trigger additional types of interviewing. For example, the pattern could be of yes-based. Yes answers could result in confirmatory questions. We could do a psychological test. For example, if the patient said, they drink alcohol, then we might administer a standardized instrument about alcohol screening. For example, the CAGE questionnaire. Have you cut down on your drinking? Has anyone been angered by your drinking? Do you feel guilty about it? Or do you have an eye-opener in the morning? If you responded yes to any of those, then it would ask additional questions of a standardized instrument, such as we see in this cascade of questions. So not only does it branch to additional questions, but it can be groups of questions or standardized instruments that are then presented to the clinician before he or she visits with the patient. The output to the physician could be a simple format that we see that's a traditional medical record. And this would include the history of the present illness, the past medical history, appropriate social and family history, as well as a review of systems, not shown on this screen. What's most interesting about instant medical history is that it can interview the patient in levels of detail that are more intense than would commonly be done by a clinician. For example, the sample that we see on this screen indicates that the patient has a rather extensive sexual history that we might wish to address clinically, but would probably, as a clinician, be a little uncomfortable in collecting. We know that computers are much better at collecting socially sensitive information from patients, and this would be a typical example. When we do the self-assessment scales that are administered, such as the mental health inventory that's shown on this screen, and there are 300 different scales, I think, incorporated into the branching of instant medical history, we see that this is a 5-item version of an 18-item standardized instrument, that the patient scored a 23, which failed the mental health, and then we see the scoring key below. This is in the United States, allows us to have a quality code for improved quality in screening for this. Certainly this is a real issue in healthcare, to figure out how to do standardized screening for things like depression in a typical patient visit. We use these types of instruments during every visit for any complaint. It then goes into the medical record, and we see, although you can't read it, this is a typical medical record in which the information would be preloaded in the subjective portion of the record, so that the symptoms are there as the patient is seen for the visit. And we'll look at this workflow in just a minute. So what do we have what's the value of a pre-visit interview? Well, it saves time during the encounter. It allows the physician to focus on the positive findings and the pertinent negatives, rather than simply asking yes/no questions in a sequential format. As a result, physicians can save several minutes with each patient and can see several additional patients in a day very effectively because of the efficiency of data collection. In fact, what happens is the physician just concentrates on the abnormalities. The documentation is improved. We have data entry time is reduced, and the documentation is complete. We can have an increased accuracy of the documentation because it comes directly from the patient. Something that's always concerned me is that why is it that a patient could go into 3 different doctors with the same presenting complaint, and the medical records from the patient's standpoint come out in 3 different ways? When you think about how this data is actually biased from the perspective of the provider, then you understand that we need patient-level information in order to meaningfully analyze outcomes. Because if we are able to look at what the patient actually had in an unbiased way, then we can decide what the outcome really means. So the documentation is better. And finally, patient satisfaction is improved. The patient-physician relationship improves because the patient sees the physician is listening to him or her in the first time often. The patient experiences a more productive encounter because the patient's had the control of the ability to put in the complaints that he or she found that she would like to discuss with the physician. And finally, the physician's actually able to listen to the patient instead of typing medical into the medical record. And we're going to show how that actually looks in real time as we visit a patient through my clinic. So, how does it really work? How does a pre-consultation really work? And there's actually 3 different workflows, and I apologize for all of the arrows in this screen, but basically on the left is an encounter with the receptionist, either in person or in the telephone. The patient in the top might do the pre-consultation interview at home, and then over on the right it goes into the electronic health record as discrete data. The second workflow is the patient could call the receptionist and be directed to a kiosk, not necessarily in the physician's office, might be at work, or in another place where a pharmacy, for example, where the patient could go and complete information on the kiosk. And certainly I have sitting with me to my right one of the world's experts on kiosks, Dr. Ray Jones, who will find this slide interesting in the different workflows that can be employed.
Indeed.
So, but the patient could also check in the traditional way and then be directed to the kiosk. And certainly there will remain some degree of waiting if the patient requires then to do the appointment, or possibly in the waiting room, and then the data is put into the electronic health record. The third workflow at the bottom is that the patient checks in and simply utilizes the old way of being seen. In other words, the nurse calls the patient from the waiting room and then is taken to the examination room, and in the examination room the patient completes an interview before the patient is seen by the physician. And again, the electronic health record has all the data. So we see these various workflows that would facilitate a pre-visit or pre-consultation evaluation of patient-entered data. And these all have to be available because patients don't all do it exactly the same, and we have to be flexible. One system will not work for all of the patients, as we all know in healthcare. So a kiosk might look, as we see in this picture, it might be a simple flat screen touch screen. These are quite nice and very patient friendly. We see these in many other applications, checking in for the airplane, to now some stores are beginning to allow self-service kiosks. So certainly these will come to healthcare. And on the right we see a very simple and inexpensive setup in which a PC is just connected to the network on a very inexpensive stand with a keyboard. Where would you do the screening? The answer is any place you can find a empty space. And certainly this is an example of a subwaiting area where you can see the exam room in the back, and the patient just comes in and does this in a private way. So you have to look at the workflow in the facility, look at the practice, and figure out what's the best way to actually implement patient-entered data. So now let's follow some patients through my office to have an experience of what it might be like as a patient in Columbia, South Carolina. I apologize for the road noise in this one. Patient comes into the office. And this will be a patient that does not do instant medical history at home. And you see the patient does what he always did. Have a seat, someone will be with you. This is a traditional workflow. Now let's look at the alternative in which the patient may have done instant medical history at home. Again, comes in, he knows to go to the computer. Now he's directed to go directly back to be seen by the nurse. Now, if you'll notice, in the foreground of that was a patient who was sitting there, and she did the traditional way, and she would naturally ask, well, how did that patient get to be seen a little quicker? And the answer is he completed his information on the internet. And that's a way that we motivate patients to complete their data in advance, because it speeds their process of being seen. And I think patient access is an important aspect of this. If we can make the experience better for patients, better service, we improve patient satisfaction, and we also encourage patients to appropriately see us and share with us the information so we can improve quality. So let's see what the nurse does. The patient, normally the next thing to be done in the practice office is the patient will have her vital signs taken. Now here's a traditional looking nurse taking blood pressure with a manual sphygmomanometer, but we'll see it's a little different in my office, in which the patient comes in.
Morning, Mr. Price.
Morning. How are you doing today?
Doing fine. Come on in.
Fantastic.
Pull your jacket off for me. Let's get a check on your blood pressure.
Oh, you're going to see if I'm still alive.
Yes, sir. Hope so. Okay. Been feeling okay?
Doing great.
Good. Good. Gonna relax your arm there.
All right.
Now we see that we're using electronic systems that go directly into the electronic record. Now let's go to the exam room.
Okay, Mr. Price, come right on in here for me and have a seat in the chair. Well, what kind of problem are you having today?
Well, for the last week or so, I've been having a problem with my left knee here.
Oh.
So,
Okay, well, we can help you with that. I'm going to enter your complaint here. I'm going to have you answer some questions. And what we're going to do is I'm going to have you answer with the red key here, okay?
okay.
I'm going to have you sit here on the stool for me. And be careful there.
All right.
There you go. And just read the question.
The nurse watches him. He completes the questions in his own time in the exam room. She watches him for a couple of questions, and then she leaves with the door open so she can tell if he's having any problems. And you see he's taking his time reading the questions quite intently, quite accurately. The way we do that is we use very inexpensive fingernail polish on the Y and the N keys of the keyboard, so that even our most elderly patients have no problem if you see the yes has a line underneath it, and we're able to explain to them, just simply press the letter that has the underlined key. Instant Medical History also has the ability to use numbers that they can enter if the provider would prefer this. So this allows even the very elderly patients who've never used a computer before to enter answers to very simple yes/no questions on our computer keyboards. And many have said, this is the first time I ever used a computer, and they were surprised by how easy it was. In fact, most patients can enter data. In our practice, we find that 70% of patients enter the data over the internet because they've figured out that it's much quicker and in terms of their visits if they do so. And the expectation is we have to have this information, and the way we explain it to them is the checklist. Like whenever the pilot gets on an airplane, the pilot goes around and does a checklist of all the things, looking at the airplane and so forth. Just as you as a airline passenger, if you overheard the pilot saying, you know, today I don't think I'm going to do that checklist because it's raining outside and you might not want to get on the airplane. It's the same thing that we communicate to patients, that this is basic information that we need to assure that our quality is consistent and we're getting all the information. Because certainly it's not that doctors don't know what to do, it's they don't have the data. And this is a way that we have a standardized amount of information about each patient so that we can improve our quality of care. About 20% require help when they do it in the exam room, just as we demonstrated with the movies, in which the nurse explains to them how to use the keys and the red keys, and then they answer the questions. And then finally, there are some patients who are just simply too sick or too ill to answer, and then either the nurse helps them, or oftentimes the patient has been brought to the office by someone who can read the questions, and then that person answers the question. So we're able to get all of our patients to doing it. It's an acceptable part of our medical practice, and again, we've done it in 50,000 sick people for the last 20 years. So it's pretty, the workflow is pretty well down to a smooth workflow at this point. The medical literature certainly supports what we do. 83%, this is a 1998 study, and then a 1991 study showed about 90% of patients. I might point out that the Charity Hospital study was actually in a very uneducated population, and it was in urgent care rather than standardized family practice. And of the 17% that were unable to complete the questionnaire prior to being seen, one actually had an axe in his back. So in instances that are more traditional family practice, I think your numbers will actually be a little bit more toward 90, which is what we experience. Now, what's also interesting is that the staff has a great influence on this. And there's an anecdotal study by a physician who actually changed practices. And he had a champion of the patient-entered data in the practice he was in, and 97% of his patients were able to complete it. Whereas he moved to a different practice where they didn't have the staff was not under his direct control, and they were sort of neutral on the use of patient-entered data. And the same physician, using the same software, found a decrease by 50% of the utilization of patient-entered data. So we know that staff enthusiasm and encouragement about how important this workflow is has a real impact on implementation success. So it's not about software, it's about workflow, which is what I'm trying to demonstrate in these movies. So let's go to the clinical exam, and that's where I get to appear in the movies, and we'll see how I examine patients. Hello, Mr. Price.
Wenner, how are you doing today?
Good.
Excellent.
What's bothering you today?
Oh, I got a problem with my knee.
Okay, let me look in the computer and see what you entered in today. Oh, I see your left knee's hurting you. It hurts you all day. You've been doing some yard work. Tell me how it affects your life.
Well, out in the yard working with the mowing the grass and such as that, it has some severe pains right in the joints there.
This is a way to allow me to ask open-ended questions, such as we were taught in medical school, of the patient. How is your illness affecting your life? Instead of, where does your knee hurt? Show me how it hurts, and so yes, no questions. These are all gathered for me so that I can concentrate on the important issues that the patient has entered. Notice that I looked at the screen and had respect for the patient who entered the data. It's very important that the patient know that you use the information that he or she has entered prior to the examination. Some physicians actually give the patient a printout of that information, allow them to correct it before they're seen. Certainly the patient has a copy of that if it's done on the internet, and I like to let the patient know that I appreciate their having done the data entry for me to help me, and how it does help me. In addition, I think that it wastes the physician's time if I say to the patient, have you had your gallbladder removed? And the patient responds no. I think I've wasted the patient's time and my time, because we know from the medical literature that medical software can gather this information very effectively. Okay, Mr. Price, I'm going to let you get undressed, take off your socks, shoes, and get up on the exam table.
All right.
In the time that the patient undresses, notice that I'm actually entering my information into the medical record of the subjective. Now we know that the subjective is 70% of a medical visit, so that I'm 2/3 finished editing this information with the data that I've that's been revealed in the clinical interview. Also notice that in no way has the software interfered with my interview of this patient. I'm doing everything I always did. I'm not letting the computer get in the way. I'm simply using the computer as to augment my skills as a clinician. I have more information. I do everything that I always did in terms of interviewing. Now let's watch how I examine the patient. Okay, I'd like for you to go ahead and get dressed, Mr. Price, and we'll talk about your knee.
All right.
Notice I'm actually doing the medical record in real time while the patient gets dressed. And this usually gives me enough time to document my physical exam, what findings I collected. Now as he sits down, I'm actually ready to share the information of the diagnosis and prescription with the patient. And you notice the placement of the exam table.
Mr. Price, I'm going to write you a prescription for your arthritis.
All right. So I'm going to have to take medicine for it.
You're going to have to take medication. Let me go ahead and show you how this prescription works.
I'm actually writing the prescription. Notice how interested he is in seeing what I'm doing. I'm actually using EHR software. See how he even got closer.
It's checking for allergies. I see you don't have any allergies to this medication. Do you need any of your other medications refilled?
Not today, sir.
Okay. And I'm going to fill in the diagnosis. This is osteoarthritis. It's degenerative arthritis. And I'm going to give you a handout about it and let you watch an education video. Does that sound like something that will be helpful?
It could be, yes, sir. I need to know all I could about arthritis, especially in the knee.
Absolutely.
Because I want to continue doing the yards and all that.
That's excellent. And I know you'll continue to be very active.
This is an opportunity now for me to talk to the patient about his condition, tell him what's wrong and what I'm going to do about it. So oftentimes physicians are rushed by the inability to explain the diagnosis because they've spent too much time trying to figure it out, whereas I'm able to spend more time on what the patient is really interested in. I think this demonstrates how we can improve quality with better information and then have more time to actually spend with patients in the way they would like, helping them with their illness and patient education. In this case, I may have him look at an information video right on that screen before he leaves the exam room, or I may give him a web link so that he can do it on the internet at his own convenience. So why does it work? Well, it spotlights the medical history. Instead of spending time figuring out the diagnosis, I can really come in and have a pretty complete history when I look at the output. Then I can focus on the patient and spend more time telling him what's wrong with him and what I'm going to do about it. And finally, I want to make the documentation and quality a side effect of the visit rather than a central theme. So finally, let's see how I close the visit with Bachmann's Law. This is named for John Bachmann, in which you hand a copy of the visit note to the patient. This is truly patient empowering, and it may seem new to many of you who haven't thought about the transparency of giving the patient a copy of the record. But what we find is that your electronic record really works well if you can have it done immediately. So let's watch how this looks.
Well, I'm going to give you medication just like you've taken before, and I want you to continue it.
All right then. So,
Let me get here's your medications. Here's a copy of your visit note, and here's your patient education about your problem.
all right.
Mr.
I'll read
Price,
up on it.
it was a pleasure to serve you.
Thank you, Dr. Winters.
Is there anything else?
I think that'll be it for today. If I need you, I'll come back again.
Bye. It's a pleasure to serve you. How many times are we so rushed that we can't think about what a pleasure it is to practice medicine? I use these systems to help me be a better physician. I have the information, and I can enjoy treating the patients, and it is a pleasure to serve them. And I think that's, if we can make medical practice more enjoyable for physicians who don't feel so rushed, and also improve quality while improving access, then I think that's a use of technology that's very helpful. As we see, the patient has a copy of the visit note, and of course they may make corrections on it or call me later about it, but it's accurate and it's correct, and the patient understands their diagnosis in a way that they never have before because they have all the information. Truly transparency in healthcare. And in fact, at 5 o'clock, just as you saw me going to the next patient, at 5 o'clock I'm finished, all my work's done, and I'm able to leave the visit. In this picture you see me opening the door for one of my disabled patients who was the last patient that I saw in the office. So I'm actually able to walk that patient out and open the door for them. It was a pleasure to serve you today. So what's the theory of how this should work? And I'll close with this theory so you have a better understanding of what this is. In the traditional visit, the routine visit in minutes could be broken down, and notice this is a 12-minute visit in which the clinician spends about 2/3 of that visit trying to figure out what the patient has and what he's going to do about it. It takes about 2 minutes to do the examination, and then the clinician knows pretty quickly after the history and the physical exam what the diagnosis is, and because he's rushed, he or she is rushed as a clinician, then there's not much time for patient education, and he simply writes the prescription and gives the patient a quick a plan of management. And the patient often calls back with questions or creates an additional visit that may be not necessary. With instant medical history, what we hope is that we can cut the history-taking time by eliminating the negative questions and collecting the yes-no information such that the actual history time is reduced from 8 minutes to about 3 minutes of that visit. The physical examination is just the same. The time to take the diagnosis is still very quick, and the physicians are very good at high-level integrative thinking of collecting information and analyzing and making a plan. And then finally, look at the right-hand side. I'm now spending half of my visit telling the patient what he or she has and what I'm going to do about it. This is what patients remember, this is what improves compliance, and this is patient education, just as we saw. In the previous slide, we had very little time for plan and actually often omit the patient education. And this is what I believe to have improved quality in my practice using instant medical history. So let's think about what this is like, and I give credit for these slides to John Bachmann, who shared them with me. This is like mining for diamonds when you take a history. The yes-no questions are like the tailings coming out of the mine, in which they're really, you have to go through them to find the diamonds, but they're really worthless. You can use a machine for the hard, time-consuming work of grinding through the mine to get all the tailings out. And certainly you still have to be in control. You have to trust the software that it will take the history. You have to check out things, just as I walked in and did, as you the old way of asking them, well, did you really mean that your knee hurt on the right side? I'm still the doctor. I'm still performing my job as a clinician. And you still have to do it some of the old way, just to
just as a clinician. This does not replace the clinician at all. It simply enhances the clinician by an extension, if you will, using technology of data gathering to improve the data on which I can make diagnoses and formulate treatment plans. So finally, I can walk into the mine and see the diamonds, just showing immediately as I approach the mine, and certainly in this way to demonstrate how easy it is to see where the diamonds are. And finally, it's looking for the diamonds, the important parts of the history, such as we learned in medical school of how an attending can walk in and ask 4 questions and formulate a diagnosis. Well, this is what I want to do in entering the patient's room, to have a good idea what's wrong and what to do about it, so I can concentrate on the patient. So I'd like to close there, and there's my contact information that can be available in the future as well.
Okay, so I think what we'll do now is we've got plenty of time for questions and comments. Please do contact us through the chat room. What we'll do is we'll let you get some questions and comments up, and then Alan will come back here and answer them via this video window, because as we've got the technology here, we're going to use it. So comments and questions, please. And I can see that amongst those watching, we've got Professor Paul Bradley, who's from the Peninsula Medical School. I'd be interested to know what you think, Paul, about the implications of this type of technology for both the education of medical students and taking this forward from there. I know that we've also got Gordon Lorimer from NCR, who's looking at sort of the use of kiosks in patient registration. It seems to me that really combining this with the current developments in patient registration is obvious. I wonder if you've got any comments on that, Gordon, and anybody else there. Please, let's hear your comments and questions. We're going to turn the sound up a minute and give you a chance to type. Okay, Paul, Alan's just nipped out a minute. He'll be back in a second to answer your question.
The statistics for quality of information have been extensively reviewed in the Bachmann article regarding the amount of information. There's 500 references, I believe, in that January 2003 article. As well, there were 1,500 references that he had, and he only published 500 of them. But it's pretty clear that in every instance of data. The quality is far better with patient-entered data. There are studies showing sexual histories are much better by threefold. There are studies showing that patients participate more readily as a result of participating in the information. And I think the literature is pretty clear on this. This is not a question that we need much debate. Personally, I feel that it's very clear that the information is helpful. There's been a recent study that revealed that patients were, when compared to internet use of this technology versus face-to-face, there was actually equivalency to face-to-face exam as far as quality was concerned in the 4 quality measures that were studied.
Okay, there's a question, Alan, from M. Dixon about the amount of time spent on patient education in, I presume, both in that traditional versus the IMH style of consultation. How much time would be spent on patient education?
Right. I think in the traditional practice, and I'm much more familiar with the practices in the U.S., of course, but patient education has not been well funded in the U.S., and I expect it's the same to some degree in the U.K., where the diagnosis is established, but the doctor really never explains what the patient should do in complete terms because of the time frame that the physician is forced to see the patient in. So that, if you noticed, I was able to change the 10 minutes to, the 12 minutes that we had in the traditional visit. I could actually increase the patient education to about 2 to 3 minutes of the visit, whereas before I was not able to have, in the traditional way, at any time to discuss how I was going to expect the patient to do additional educating them about their conditions and what to do about it. So I think clearly by having the extra time, we allow the physicians to actually do more. And we also know from the literature that if the physician says this is important, the patient thinks it's important. The physician saying that it's important to stop smoking, or it's important to consider alcohol as a problem, or it's important to have a lifestyle change is very powerful in terms of patient changing behaviors.
Okay, I've got another couple of questions. One is from Karina Pring in Plymouth, asking about how the data is stored. Is it on sort of the individual patient records, or in, I'm not sure quite on this, but if you can say something about how the way it's stored. And a question from, I'll give you a second question at the same time, from Wiggly Amps, which is about the common languages. If you've got a patient with who speaks another first language, how does IMH deal with, how are you dealing with that in IMH?
Okay, let me talk about the data. Instant medical history is a way of collecting data. That's the purpose of our work, is to collect information directly from patients for use by physicians. So in theory, we try to develop interviews and questionnaires that would replicate how a physician would interview a patient. We then create that data model in a structured, discrete format, but then that format is then given to the electronic health record, and instant medical history stores no data. Our expertise is all in the branching, the understanding of the interview, the creation of the interviews, and the creation of the information that a physician needs. So the storage then goes into the electronic health record in whatever format that record would require. Indeed, I think we've dealt with dozens and dozens of the systems in the U.S., and they all require something a bit different.
Can I've got a comment. We've got several comments here rather than questions. Maybe if I can just sort of pick up on them. Gordon Lorimer has said that he's agreeing that it seems that patient registration is a good time which to start capturing IMH. In the States, how how many practices I've got the patient registration system. You know, just the simple, you know, patient arrives, clocks in at the moment. I mean, and do you try and capture IMH at that point, or do you move them through to another room? I got from the idea from your flow chart that really you probably wouldn't have them using the same computer for registration. You'd move them through. Is that right?
Well, I think that again depends on the workflow. I think it is an excellent plan to do it with the registration, but the registration kiosk has to be far more private than you saw in our waiting room. If you looked at the information that we're obtaining, such as some of that sexually sensitive information, you would not want to have those screens be exposed when other people are easily available. Now, a library carrel in a private part of the waiting room would certainly be appropriate. Or you saw the two machines that were back to back where the patient could register and do that would certainly work. If you have a very public carrel, I would suggest that IMH be administered in a different setting. And certainly you could allow pre-registration on the internet at home, in which it would be combined with instant medical history. And I think I showed that as one of the workflows as well. So the answer is all of the above, and you have to design the workflow that meets best for your clinic and individualize how IMH is applied depending on what your physical plant and somewhat how your workflow can be best optimized.
Okay, so the questions are coming thick and fast now. There's some comments from Adi, basically supporting the whole idea, and a comment from Robin Glasspole also asking to share a story I think that you may have told him before about how IMH detected a second more serious problem which prevented potentially serious consequences for the patient. So do you want to pick up that one first?
I think I missed one other question about when the patient's language is not primarily English. Let me just address that. Certainly, since this is all digital data, the translation of the questions is easily done in the sense that we can do any language that we can translate the questions into. Now, that having been said, certainly the practice of medicine is the same throughout the world. If you have pneumonia, you probably have green sputum whether you live in Southeast Asia or lower parts of Southwest the UK or in Columbia, South Carolina. So certainly the practice of medicine is universal. I think there are certainly there's localization that needs to be done because of the variations in disease, but by and large, the geographical application of instant medical history is an implementation rather than a theoretical issue, and so the language barrier is not significant at this point. We have the UK, if you will, UK translation, so that some of the terms that we don't use in the U.S. are changed, and it's been interesting to me to see some of the differences. But as well as a Spanish, and that's South American and Central American Spanish, but we are moving into the European languages as in the future. The story that I wanted to relate is interesting because Robin was asking me about how you would show improved quality. And I tell the story because, and it only happened a few weeks ago, actually a physician was visiting me, so I have a witness, and we're writing up this case because it shows how IMH works. The physician had actually come from a larger group, an 80-man practice from another state, had visited and said, we're having some trouble understanding how to implement instant medical history, so I wanted to come down and watch your clinic work. So I hadn't really planned to see any patients that day when he came to visit, but the nurse practitioner was seeing patients, and I said, well, why don't we just go in and see one of her patients? And it was this, so my visitor and I both walked in and saw a 17-year-old male. He was complaining of allergy symptoms, of some mild wheezing, rhinitis, and congestion. The IMH revealed very clearly that his symptoms were quite simply allergies, which he had told the nurse on the phone. However, we also apply the U.S. Preventive Services guidelines for care, of which in a 17-year-old, 2 questions of depression are used. It also has about smoking. Interestingly enough, in addition to his allergy, he also answered positively to the 2 depression questions. So Dave and I kind of looked at each other and said, these are interesting. And because IMH is customizable by the provider, the nurse practitioner did not set it to automatically branch to the additional screenings that I might have had it been set to my customizations. So we looked at the patient and said, it sounds like you've been feeling sad in the last couple of weeks. He confirmed and said, I would have liked to have talked about that, but I really was not going to. And certainly he didn't look depressed at all. And both Dr. Michael and I were quite impressed that he was not clinically depressed overtly. So we said, well, finish up these questions and we'll be back. So we went outside and came back in and found not only was he severely depressed, and actually the story was much more interesting in that he was completing his, I think the equivalent are the O levels here in the UK, and he was failing English because he was unable to concentrate. The screening showed that very clearly he had depression. Of course, the symptom of depression is lack of concentration, which would explain why he was unable to concentrate on his textbooks in English and meaningfully pass the examinations, and he would fail the entire year as a result of that requirement. So not only that, he had actually expressed some anger toward his teacher because of this, which he blamed the failing grade on her. Dr. Michael and I were amazed to hear him tell the story of his anger and his depression, which was clearly present. I called his mother to come in the next day, and after explaining his illness and how this was a biochemical problem, and we did a suicide pack. He was not suicidal, but he was somewhat homicidal, if you will, enough so that I was quite concerned. And she said, this explains why he's been this way for the last 9 months, deteriorating significantly, and he has depression. I have depression. I've taken fluoxetine or Prozac for the last 25 years. I now know. It's like a light came on in her head, and so of course he has depression. And then she explained, and he didn't actually share that he had been more angry recently. He had, and then on further questioning, he admitted that he had anger toward his patient, toward his teacher, that he had planned possibly to consider acting on. What was interesting, and Dr. Michael and I reviewed the case, is that had you reviewed this case, you would have said that treatment of the allergies was totally appropriate. The examination was complete, the history was complete, the diagnosis was correct, and the medication plan was correct. However, what we don't know would have been the depression. So the question really begs the question is, what is quality? If we don't know that this patient was depressed, then we would have never made that diagnosis, and he would not have been treated until he had gotten in more trouble with the law. In fact, sadly, the next day his mother recounted that the week before he had been arrested for vandalism because of some associations that were inappropriate. So this is an example of, is some of the things that happen in society really a failure of the medical system, or society itself? Are we missing diseases that we should be treating in the healthcare arena because we don't have the information?
Can I ask you, we're sort of pushing on towards 1 o'clock, so I've got 2 questions if we can, or 2 comments that perhaps we can deal with. First one from Paul Bradley, which says, I can see the benefit of collecting routine data. What about the emotional, psychological and non-verbal aspects of communication? Are patients channel down a technical, rational approach? Do you want to do that one first?
Well, if you saw in my videos, you saw I'm still looking at the patient. I'm looking at all the psychological cues. I'm reading the patient and doing everything I always did. I think that if anything, having the patient answer some questions in advance prepares them much better for what's appropriate about the complaint they have. In fact, the questionnaires may have things that they wouldn't have thought relevant, but then when they see the questions being answered, about that, then they know that that's much more relevant. So it prepares them for the visit better, I think.
And Richard's also answered to some degree in the chat room. I think perhaps this will be the last question is from Gordon Lorimer. We've had some nice little comments there from AD. Thanks very much for those. I think they're more comments for everybody else really rather than something for Alan to respond to. But just taking Gordon's question, which is how many locations? How many locations in the US or elsewhere? You've heard about the number of patients, but how many locations have we got?
Oh, thousands. It's part of every all the large electronic medical records in the U.S., and I know of one site that has done 4 million visits with IMH in a pre-consultative way. So I honestly don't know because it's a component of electronic records. Again, we don't sell anything directly to clinicians. It's more a component of electronic health systems in the U.S.
And I think that's it's now 1 o'clock, so I think we should probably call it an end there. Thanks very much indeed for everybody participating. Thank you, Alan, for participating.
Well, it's been a real pleasure, Ray. I have to say this is one of the finest facilities I've ever been in for this type of technology, and you should be congratulated on such a good job here.
Well, thanks for coming so long. What we'll do is we'll put Alan's contact details back up again and say goodbye. So bye.